Steve's last slide actually had a beautiful segue talking about phenotyping. And our last speaker of the day, Mike Tracy, is going to emphasize that. Mike got his medical degree at Brown University, then came out to California, where he did a pediatric residency here at Stanford and a pediatric pulmonary fellowship. He's now a clinical assistant professor in our division, and he's the director of our fairly new BPD clinic and a work in progress called CRIB, which is a cardiorespiratory care of BPD infants in collaboration with cardiology colleagues, and Mike will discuss that.
Thanks very much, Dr. Moss. So when we talk about post-prematurity respiratory disease, we're primarily talking about BPD. And I'm not sure if you guys are aware, but BPD was defined here at Stanford in 1960. You may have heard that. Dr. Cornfield's aware, Dr. Sunshine. And again, this was defined by Dr. Northway in conversations with Dr. Sunshine following these preterm infants with this new chronic lung disease. And what I wanted to highlight is that they performed this really comprehensive clinical, radiographic, and pathologic phenotyping. And this defined this new disease and really permitted understanding of the progression and stages of the disease going forward. So this initial description of BPD, we now term old BPD, occurred in the pre-surfactant era. And the lung histopathology, which you see above, really highlights the pathologic features of marked airway smooth muscle hyperplasia, extensive fibroproliferation, and hypertensive remodeling of the pulmonary arteries. This is held in contrast, again, to the new BPD, the post-surfactant BPD. And of course, the changes were not limited just to surfactant, but also to changes like antenatal steroids and changes in ventilation and modes of oxygenation. And the pathology of the new BPD, as you've heard today, really is characterized by fewer, larger, simplified alveoli with less regional heterogeneity of lung disease. But what is BPD in 2019? How do these descriptions of old and new BPD, which we still hear in our NICUs, apply to the current BPD? And I think the question I wanted to ask in this talk is the phenotype of BPD today more or less clear than it was originally defined in 1967? And what I'll argue is that the phenotype of BPD is far less clear today. And with the aid of several recent cases from our NICU, I'll attempt to highlight that and again focus on the importance of going back to the thin phenotyping of this disease, which has also been highlighted by other speakers today in other disease processes. Dr. Young drove that home in context of ILD, and Dr. Admin when describing the pulmonary vascular phenotypes. So looking at two cases which illustrate this point. So our first case here is of an infant with prenatal stressors, which included chorioamnionitis. This infant also received prenatal steroids. At birth, at 22 weeks and 5 days, the 600-gram infant was intubated, placed on the oscillator, received surfactant and steroids, systemic steroids. And at 1 month of life, was extubated to non-invasive positive pressure, continued to receive diuretics through this course. Non-invasive pressure was weaned down to CPAP, ultimately high-flow nasal cannula around 30 weeks PMA, and then down to low-flow nasal cannula by 32 weeks PMA, at 0.1, 100% oxygen at 36 weeks. PDA was followed with serial echoes, went from large to moderate to small. The second case is an infant with antenatal stressors, which included PPROM at 19 weeks. This infant also received antenatal steroids. At birth, similar to our first infant, was intubated, placed on the oscillator, received surfactant. This infant received INO for 3 days, which was noted to be of benefit at the outside hospital where this infant was born. Systemic steroids were also received for a longer course than our previous infant and at a later date, and then transitioned to inhaled steroids. Diuretics were used throughout, and a PDA remained moderate to large in description at 30 weeks when the infant remained on high amount of mechanical ventilatory support or in pressure control settings. So these cases really highlight these varying phenotypes at 36 weeks. Case 1, again at 0.1 liters per minute, 100% FiO2 via nasal cannula. See a chest x-ray here showing low lung volumes, some hazy opacities overlying some interstitial changes, compared to case 2, who at 36 weeks remained mechanically ventilated and intubated on high settings with a significant amount of oxygen, and a chest x-ray which shows notable hyperinflation with coarse reticular opacities throughout. The current definition of BPD, which goes back to the 2000 NIH consensus definition, defined BPD at this at 36-week PMA mark, focused on infants less than 32 weeks of age who had received oxygen for at least 28 days. And at that 36-week mark, it's defined as mild BPD if we're breathing room air, moderate BPD if needing less than 30% FiO2, and severe BPD was the group which included infants receiving greater than 30% oxygen and or positive pressure. Looking at our cases, case 1 on 0.1 liters per minute nasal cannula fits severe BPD, as does case 2, both within that group, showing how broad this classification is and how problematic it can be. As these two cases highlight, BPD is really a disease defined by its treatment with oxygen, like stating a child who is prescribed albuterol has a diagnosis of asthma, which is a diagnosis I gave many times last week, but doesn't make it right. So again, this is a disease defined by its treatment with oxygen, not by any aspect of its pathophysiology. No imaging, no pulmonary function testing, no labs, no histopathology. And a major consideration for the diagnosis of BPD is how it can predict outcomes. And while the initial definition of BPD I showed you did predict some respiratory outcomes at 18 to 22 months, other studies have shown that other clinical factors like male sex, IUGR, may be just as good as that initial BPD severity diagnosis at predicting outcomes. And more importantly, as I've tried to highlight, this definition lacks precision for testing new interventions. It's such a broad group. So how can we update this definition? Several groups have focused on the severe BPD group and separating out infants on low-flow nasal cannula with higher levels of respiratory support. The BPD Collaborative, here led by Dr. Abman, and their interdisciplinary care of children with severe BPD published in 2017, suggested breaking up the severe BPD group into type 1 severe BPD, here on the left, infants greater than 30% oxygen, CPAP high flow, versus severe BPD type 2, infants with mechanical ventilation. Applying these criteria to our cases, case 1 would meet type 1 severe BPD, case 2, type 2 severe BPD. Another group, the National Institute of Child Health and Human Development in 2018, their workshop again focused on a similar way to separate out BPD severity, here by 3 grades, you'll see on the left, grades 1, 2, and 3, again by focusing on amount of respiratory support and also percent of oxygen. Applying this to our cases, our case 1 infant would meet grade 2 BPD severity. Our case 2 infant would meet grade 3 BPD severity. Okay, so they're severe BPD type 1 and 2 or grade 2 and 3. What do I do with this at the bedside? Well, I go back to the literature, find another publication by Dr. Abman, and I look at the framework for post-prematurity lung disease. And so here I have our case 1 in green, our case 2 in red. Both have extreme prematurity. That would be great to focus on preventing prematurity as a first step, but if we're left with these extreme premature infants, we talked about and heard from Dr. Abman already the importance of the antenatal stressors on these infants. These infants, one was PPROM, the other had chorioamnionitis. They both had multiple postnatal factors which contributed to their disease: supplemental oxygen, ventilator injury, and what's the role of that PDA? Patent ductus, which I talked to Dr. Bennett about for 30 minutes earlier today, and I'm not any closer to knowing. But that's not his fault. That's on me. And then, both of these infants had injury and developmental arrest, but had these marked different outcomes. The first infant is heading towards disease resolution, hopefully, while the second infant has this persistent respiratory disease. So how can we separate this? How can we understand this? So starting with genetics or epigenetic factors, when we discuss precision medicine, there's this growing focus on the Omic approach. And previous speakers today have well outlined the pathways involved with normal and disordered lung development. We were just speaking about angiogenesis. We heard about alveolar septation and inflammation. And large-scale data sets looking at genomics, transcriptomics, microbiomics, proteomics are all really attractive in that they can use samples which can be collected fairly non-invasively and can enable longitudinal sampling and analysis. And there's undoubtedly merit in this approach for better understanding underlying pathogenesis and development of BPD. But in addition to the Omic approach, again, as I've already said, I feel like this return to thin phenotyping is a key component to separating the outcomes of these infants and will be essential for continuing to improve our animal models, lead towards clinical trials, and study outcomes. And how can we phenotype? We can phenotype by going back to the physiology, and I'll break this up into 3 categories. The first will be thinking about the airways. So what do we know about the airways in BPD? We know the central airways, tracheomalacia, bronchomalacia, subglottic stenosis can play a major role in the large airways. And in the small airways, we can see reactive or fixed changes in the small airways related to chronic obstructive physiology. The parenchyma, we've already discussed the impaired alveolar development that we particularly see in new BPD, with a component of alveolar damage on top of that, often in the context of postnatal stressors. And then the third category would be the vascular phenotype that Dr. Admin so elegantly just outlined, with a decreased vascular bed, abnormal remodeling, tone, and reactivity. And I found this presentation recently on a retrospective cohort of 76 preterm infants with severe BPD cared for at CHOP from 2011 to 2015. And this study sought out to characterize the frequency of parenchymal disease, pulmonary hypertension, and large airway disease with chest CT, echo, and bronchoscopy at 40 to 50 weeks, PMA. And they found of this cohort, 75% had parenchymal disease, just over 60% had vascular disease, and 50% had airway disease. But most interesting was the overlap of infants who had all 3 phenotypes. That was by far the most common. 28% of these severe BPD infants had parenchymal, vascular, and airway phenotypes. So how can we phenotype going in 2019 and going forward? I'll touch on some of these, highlighting recent publications, looking at bronchoscopy, pulmonary function testing, advances in imaging, echocardiogram, and then biomarkers. Biomarkers is a broad term, and a lot of the focus of biomarkers, as Dr. Hammond just alluded to, with cord blood and endothelial progenitors, and even some recent exome work, gets at predicting who develops BPD, but may have a role also in once BPD is established. So first phenotype, airway, thinking about bronchoscopy and how we can use bronchoscopy. Here I'd like to highlight a retrospective cohort study of neonates with BPD who underwent bronchoscopy enrolled in the Children's Hospital Neonatal Database from 2011 to 2016. And the goal here was to assess the effect of tracheobronchomalacia on clinical outcomes. They looked at 974 infants across 27 NICUs, and they found, as illustrated on the left here, looking at the adjusted duration of mechanical ventilation with days on the y-axis and no tracheobronchomalacia or tracheobronchomalacia, which is hard to say at the end of the day, on the x-axis. They found that infants with tracheobronchomalacia on average had a 3-week longer duration of mechanical ventilation than those without tracheobronchomalacia. And on the right, infants with tracheobronchomalacia had a higher rate of having surgical interventions, including tracheostomy and gastrostomy. So thinking about the phenotype of infants with airway abnormalities, should we be thinking about doing more bronchoscopy to look for this? And if we do find it, are these infants who we should be thinking about tracheostomy earlier in the course, or thinking about clinical trials to look at agents that can increase tone of the tracheal smooth muscle? Next way to think about the airways, infant pulmonary function testing, and a recent publication in 2018 set out to see if infant pulmonary function testing could reveal distinct phenotypes in severe BPD in the initial NICU stay. This prospective cohort study, with data previously collected in infants from severe BPD over a long range from 2003 to 2016, aimed to classify infants as either having an obstructive, restrictive, or mixed phenotype. The median age, postmenstrual age, was 52 weeks when this testing was done. And the authors showed that looking at 110 patients, 51% of patients had an obstructive phenotype, 9% had a restrictive phenotype, and 40% had a mixed phenotype. They then attempted to see if these patients were bronchodilator responsive. And here we see the percent of patients in each phenotype who were bronchodilator responsive. Not surprising necessarily, the obstructive phenotype had the highest percent of patients who were bronchodilator responsive. But of note, of the responders, they had a lower baseline FEV 0.5 than did the non-responders, suggesting that this subtype of obstructive phenotype with a lower FEV1 at baseline may be a group to highlight further future interventions in trials of bronchodilators. They also noted that the restrictive component, which as expected had the lowest rate of bronchodilator responsiveness, more likely responded to other clinical interventions like coming off positive pressure earlier in the course, with a very different ventilator strategy from those with an obstructive physiology. Moving on to the lung parenchyma as the next phenotype, thinking about what new imaging techniques we have. This is a paper published in 2018 looking at 42 neonates across the spectrum from no BPD to severe BPD who underwent quiet breathing structural pulmonary MRI inside a NICU without sedation or respiratory support unless it was clinically indicated. Disease severity was scored independently by 2 radiologists compared to clinical severity by the BPD definition, and short-term outcomes were assessed. The age at MRI in this group was between 37 and 42 weeks PMA. And what they found was that quiet breathing MRI can describe disease severity and predict respiratory support at NICU discharge. So here we have BPD MRI score on the y-axis, with more severe parenchymal disease having a higher score. On the x-axis, respiratory support at NICU discharge. We see that infants with a higher score with worse parenchymal disease were more likely to require a ventilator at NICU discharge. Thinking about how we could apply this, is it possible that an MRI at 37 weeks with a severe BPD MRI score may lead us to go towards tracheostomy earlier in a course? That decision of when to pursue tracheostomy is often a challenging one in the NICU setting. And then imaging can also bring together multiple assessments of phenotype. Looking at the airway and the parenchyma together is a possibility now using hyperpolarized gas, which can give regional information about respiratory structure and function, which PFT testing alone cannot. So combining those two things together is quite intriguing. There are technical issues which have made it not be very slowly to be implemented. But this one study from 2017 used hyperpolarized helium diffusion-weighted MRI in children with BPD. And these were 5 and 6-year-olds, not our infants in this case, but compared with age-matched children. When we look at these two diffusion maps with healthy children on the top and children with a history of BPD on the bottom, hope you can appreciate the heterogeneity of the diffusion in the BPD infants compared to the healthy controls. Thinking about how we can apply these techniques going forward is quite intriguing, both from instituting new therapies or using this as an outcome measure. The vascular phenotype Dr. Ammon just outlined so well. Here I'm highlighting the 2017 PPHNet recommendations for evaluation and management of pulmonary hypertension. And while cardiac catheterization is the gold standard for describing this phenotype. Echocardiogram is, of course, by far the most applied in BPD with reasonable sensitivity for detection of pH. And when diagnostic studies are consistent with pH, brain natriuretic peptide and NT-proBNP are measurements that can assist with assessing cardiac performance over time. It can serve as a useful biomarker in that respect. Here at Stanford, we've applied these recommendations through our CRIB program, which Dr. Moss alluded to, our multidisciplinary approach between neonatology, cardiology, and pulmonary. And based on these guidelines, we screen infants at 36 weeks of age who meet criteria for moderate or severe BPD with an echo and NT-proBNP. On the left, if infants don't meet initial criteria for pH but are still on oxygen at 40 weeks, we repeat those screening interventions. And if they're off oxygen at 40 weeks, we continue to follow them outpatient at 6 months, again screening for late pH in this group. On the right, for infants who meet criteria for pH, the focus is again on evaluating and treating lung disease, going through the other phenotypes that we've just outlined, and often getting to other diagnostic measures like CTA, which can also identify other areas of pulmonary vascular disease like pulmonary vein stenosis, and maybe a step prior to going to cardiac catheterization. So coming back, as we discussed, one of the main concerns with the present oxygen-based BPD definition is the difficulty in predicting short and long-term outcomes. So with improved characterization of phenotypes with these new diagnostic modalities, can we improve the definition of BPD and lead to meaningful prediction of outcomes? And these outcomes can include recurrent exacerbations, rehospitalizations, rates of reactive airway disease, exercise intolerance, and as Dr. Edmond was just mentioning, that adult lung disease and pulmonary vascular disease. So our next steps, applying these new strategies to phenotype, and in particular choosing which infants to treat. Is it all infants? Is it just the more severe subtype? And then validating with outcome measures which diagnostic methods will reliably identify outcomes of interest. And then lastly, applying these newly defined subtypes to new experimental models and designing new clinical trials is the ultimate goal. So that wraps up my quick overview of how to phenotype BPD in 2019. I'd like to thank Dr. Cornfield, of course, mentor and division director in Pulmonary, along with my colleagues who have really joined together with me to create this multidisciplinary team in neonatology, Shazia Bombal, Alexis Davis, and Ashley Forrester, and in cardiology, Rachel Hopper and Jeff Feinstein. And I think together in our program, we really do try to assess this broad phenotype. And lastly, I'd like to thank my mentors in the Pulmonary Division, John Mark and Rick Moss, for their support throughout. So thank you. And I should say this infant here is my daughter at 4 months, who is on 0.0% oxygen and is defined as having a follower who's a pulmonologist and needed a picture for a website.